Welcome back to Meet in the Middle. I'm Christine Brown, and what we're going to talk about now is a birth defect. The name is really unusual. You probably are not even familiar with it, but it's called anancephaly. And with me today is Dr. Amy Person. She is the you're like the county doctor, but with the Benton Franklin Health District. But what is your title actually?
I'm the health officer.
Health officer. Okay. So, Dr. Person, first of all, share with us, what is this birth defect? I mean, most of us, aren't really that familiar with it.
Well, anancephaly is a rare birth defect that affects the growth and development of the spine and the brain. It has kind of a range. The more milder forms of it are called spina bifida, and then the most severe is anancephaly. And anancephaly literally means without a brain. So babies that are born without their frontal lobe, without their brain. Unfortunately, this is a fatal birth defect, so the babies may survive for a short period after birth, but without the brain, they can't survive.
So, is this a do parents know about this birth defect before the child is born?
Often they do if the mothers are receiving prenatal care.
Okay.
It occurs very early in the pregnancy, probably by even before the end of the first trimester. It has already been defined. So women, when they often get prenatal ultrasounds, it can be seen on that. There are some lab tests that are done as general screenings for defects that will pick this up. So the women usually are aware, which can make it difficult. It's difficult to be faced that early in pregnancy knowing that you have a child with a defect that is not compatible with life.
Yeah. So this is a rare birth defect, but why is it an issue in Yakima, Benton, and Franklin counties?
Well, what happened was about 3 or 4 years ago, a healthcare provider had noticed a couple cases of anancephaly in a short period of time, and so was concerned that they were seeing, even more than one of this very rare defect. So they contacted Benton Franklin Health District, and we contacted the State Department of Health to help us look into this issue. And so through cooperation with the local health districts and with our local health care providers, we kind of gathered information on that and discovered that we were seeing higher than expected numbers of this. Typically, this birth defect occurs in about 2 out of 10,000 pregnancies. In our area, we were seeing a rate closer to 8 out of 10,000 pregnancies. So our rates were about 4 times higher than expected.
4 times higher. All right, so if you are listening today and you want to make a comment, you have a question, don't hesitate to call. Our number is 547-8726. Okay, so I know that some, research or study of this has gone on. Can you rule out, or what do you know about what causes it?
Well, what we know is sort of information that's been gathered from other states, other places where they've seen increased rates of this at different times over history. Probably the largest cluster of this had occurred down near Brownsville, Texas, and so a lot of our data and thoughts about it comes from their work that they've done over many, many years. The things we know that affect anancephaly are one, if women don't get enough folic acid supplementation either before pregnancy or early on in the pregnancy. Certain medications can affect it. Obesity can affect it. We know that this is more common in Hispanic women, although we're not sure why that is the case. And we know that if you've had one pregnancy affected by anancephaly, you're more likely to have subsequent ones affected by that as well.
Mm-hmm.
So when we had identified this larger than expected number of cases, we tried to look and see if any one of these factors was more significant in that group, and we couldn't identify any one of these factors that could give the full explanation.
Mm-hmm.
We've also tried to look at other patterns based on employment, where people live, what their water supplies, because we know that in our area there are certain things that oftentimes come up as possible areas of concern.
Mm-hmm.
Obviously Hanford comes up as an issue with almost any kind of
Yes.
health
Yeah. Mm-hmm.
health risk. So we did consider that, but again, looking at the patterns of where the women lived and what their employment was, we couldn't make that association between radiation exposure and this defect. We also know historically from looking at, say, studies in Japan, in Hiroshima after the atomic bomb, they did not find associations between radiation and this specific birth defect.
Mm-hmm.
Our area has a lot of agricultural industry, so obviously there were concerns about pesticides, nitrates in the groundwater. So again, we looked at water supply. Majority of the women got their water supply from city water, not from wells. And again, based on their employment and where they lived, and also looking at the times of years when this occurred, it doesn't appear to have any pattern associated with pesticide applications or agriculture. With any rare defect, particularly when there are many, many things that contribute to the cause, trying to find that single one thing that's going to explain it in our area is going to be very difficult, if not impossible. We considered and we continue to look at the data and try to look at anything that might be added as a additional explanation. So
Mm-hmm.
the work continues to go on in terms of this investigation.
Well, all you have to do is Google it, as I did, and you come up with the news stories, or I don't want to say they're news stories, but stories, blogs, things that people have written that do tie it to, or conjecture that it's tied to Hanford. And we do have a lot of, you just listed off some, but between Hanford and agriculture, and then at one point we had the chemical weapons, in Hermiston being destroyed, mustard gas and that sort of thing. So we have a lot of potential issues here that typically get raised whenever anything like this is hard to explain. So I guess next I want to know who all is working on this. I mean, it sounds like a lot of avenues have been walked down, and maybe, I don't want to say exhausted, because there could always be a lot more research, but who else is looking at this?
Yeah, well, just within our area, we have an advisory committee that is composed of people from the State Department of Health, from local health jurisdictions, community health providers, CDC and other national experts on birth defects, March of Dimes, various community organizations, continuing to work on what we need to do next. What is the best way that we can help our community?
Mm-hmm. I'm going to take a break here, but if you have a question, here's our number, 547-8726. When we come back, one of the most important things that I think we should talk about, Dr. Person, is what women should do if they're thinking about being pregnant or if they are pregnant, and what kind of health care is best for them. So we'll tackle that when we come back. My guest today is Dr. Amy Person. She is the health officer for the Benton Franklin Health District. We're talking about anancephaly, which is a very rare birth defect, but it basically means that the brain does not develop. Babies cannot live long term. Their lives are very short because they basically don't have a brain. It has an incidence here in our area, which is Yakima, Benton, and Franklin counties, that is 4 times higher than other parts of the state or other parts of the country. So it has been tracked or looked at, really, information gathered, Dr. Person, for the last 4 years. But what was going on before that? Do we have any idea what its rate was?
That's one of the things that we are looking at. One of the issues that sort of was identified early on was how we track this kind of a birth defect, and this is a little bit where we talk about the difference between active and passive surveillance. So hospitals and healthcare facilities are required to report when a baby is born with a major birth defect like anencephaly. But obviously, with a birth defect like this that you know is going to be fatal, there are a number of women who will choose to terminate their pregnancies rather than carry the pregnancy to term, particularly since this is one that is identified early on. So there was no mechanism in place to track terminations as a result of birth defects. So a lot of the work that we did in terms of identifying the number of cases was that the CDC and Department of Health staff actually went to all of the hospitals and to all the OB and family practice providers in our area to look through their records to try to identify if they'd ever diagnosed any cases of anencephaly, to include those that were ones that were terminated prior to delivery. So one of the questions is, whether the information we have from the past looks lower because it was more of the passive surveillance, waiting for the hospitals to report the cases rather than our more intensive active surveillance. So part of the work that we are doing now is looking back as best we can from some of our older data, older vital statistics data, to see, is this a trend that is a recent one, or is this something that has been going on for a longer period of time?
Well, your office and you have been criticized because you didn't jump on this sooner, or perhaps you're not as aggressive as some people would want you to be. What would some people who are in that category expect you to do? What do they want?
Well, I think what in the end everybody wants is, of course, for us to, find a reason and to stop that reason. And we would love to be able to do that too, but I think it's not going to be that simple to do that. There are a lot of theories that float around, and as I spoke about earlier, we did try to look at possible associations between things like pesticides and radiation, kind of some of the common concerns that are raised. There's been criticisms that we haven't done enough outreach, and that's something that we are working to address, but our resources with this, as with many other things, are limited, but we are looking at kind of teaming up with as many community partners as we can to address that. There were concerns that we didn't interview the women soon enough, and our approach to this was that while a lot of people sometimes want something done right away, we wanted to make sure that what we were doing was going to be the best, most sort of effective things, not just the fastest things. So we are in the process now of interviewing women who had pregnancies affected by anencephaly within the last 3 years, to see what kind of information we can gather from that. But obviously interviewing people it's not something you can just walk in off the street and know how to do. It's a skill in order to be able to get information that can be useful. So that's something that, again, took time, but that we are working on doing that now.
It's kind of like a big needle in a haystack, isn't it? I mean,
it is a big needle in a haystack. you know, we're trying to look at, you know, from our initial studies, you know, there were 27 women that were affected out of over 30,000 pregnancies. So we're trying to figure out what was different in the lives, in the exposures, in the histories of 27 women compared to the other 30,000. And that's what's hard, because there are a lot of things that people can talk about, again, like pesticides or like Hanford, but there are a lot of people who were exposed to the same kinds of things whose pregnancies were not affected. So just knowing that we have pesticides in the area is not enough for an explanation.
So this is all about, this comes from a woman. It does not come from the genetic side of the partner, the man?
Not that it's been identified yet, but actually, you know, what we are learning about genetics and about epigenetics is that there might be things that happen on the fathers, on the paternal side, that may affect it. So there's probably a whole other can of worms that we haven't even been able to scratch the surface of. But because, like I said, there are many, many things, I think, that affect this. So it's unlikely that we'll be able to identify the one reason why we're seeing more of this. So a lot of our efforts now are focused not on just trying to prevent a single birth defect, but we're really trying to focus on making sure that all women have the healthiest pregnancies they possibly can have.
And you had mentioned that you do that basically collaboratively, so you work with other organizations that have, that somehow touch the lives of women who are pregnant as well. That seems like the best approach possible, because there's no way that your office alone can make all of those kinds of communications. So using people that are already out there and having interaction with women thinking about being pregnant or who are pregnant is a good approach. What is your number one advice to people, women who are going to be pregnant, who are? What do you tell them?
You know, and again, our message is the same for all women who are considering that. One of our key messages is we want to make sure that all women who are of childbearing age, so not just ones who are actively thinking about getting pregnant, but any woman of childbearing age is getting enough folate, enough folic acid, which is a vitamin. You can get it through food, or you can get it through vitamin supplements. One of the concerns that's been raised in the past is that corn masa is not fortified with folate the way that a lot of other cereals are, and I think that has something to do with the fortification process.